Assalamu alaikum. The long clinical consultation day. First scenario, Mr. John Smith, 62 years old, presented with fever. His temperature 38 since 2 weeks. Please take history, examine the patient, and address his concerns. Ready?
Yes.
Yes, here you go.
Hello, this is Dr. Iman, one of the doctors today. May I confirm your name and age, please?
Yes, Muhammad 62.
Okay, so Muhammad, what brought you to the clinic today?
Yes, doctor, recently I have high body temperature.
Since when you have had this high temperature?
Since 2 weeks.
And does it increase progressively or?
Yes, doctor, recently has become more progressive and increase.
Okay, and is it continuous?
Yes, doctor.
Okay, does it associated with any chills or night sweat?
Yes, doctor, associated with the sweat.
Anything relieves the fever?
Yes, doctor, I tried to take some paracetamol, but there's not improved.
Did you try anything else?
No, doctor.
Okay, have you noticed any weight loss with the fever?
No, doctor. I have weight loss since long time, doctor.
Since how long?
Since 2 years back.
And how much is it?
I think 5 kg over since long time.
Okay. Is it intentional or? I mean, did you follow any diet or was it unintentional?
It was?
Did you follow
Is
any
what
diet?
unintentional?
Okay.
No, doctor.
Okay. Have you had any sore throat or cough recently?
No, doctor.
Any runny nose?
No, doctor.
Okay. Any diarrhea?
What you mean by diarrhea?
Sorry, mean loose stool.
No, doctor.
Okay. What about your waterworks?
What do you mean, doctor?
Any urgency? I mean, any pain while urinating?
No, doctor.
Okay. Um, any chest pain?
No, doctor.
Um, any palpitations?
What do you mean by palpitation?
Heart racing or you feel your heart beats?
No, doctor.
Okay. Any headache associated with the fever?
No, doctor.
Did you notice any skin changes recently?
No, doctor.
Any joint pain or any joint pain?
No, doctor.
Okay. Have you been any history of sick contact?
No.
Any recent travel?
No.
Okay. Um, do you have any long-lasting illness?
Yes, doctor. I have a cancer.
When you were diagnosed?
Bowel cancer.
And when we were diagnosed?
Since 1.5 year.
Do you take any treatment for it?
Yes, I took medication which they call chemotherapy.
And for how long is this?
Started the chemotherapy since 1 month, since one years back.
1 year back. And the recent session, when was it?
Every month, doctor, last session.
Every month. And are you doing well with management? I
Yes,
mean,
doctor.
okay.
Mm-hmm.
Okay.
The last session was last 3 week.
Last 3 weeks.
Mm-hmm.
Okay. And you haven't had any side effects or nausea or vomiting?
Yes, doctor. When I took the cycle of the dose of the chemotherapy, I developed some to the throwing up. But the doctor gave me some medication before I give before this medication before chemotherapy.
And can I know what is it?
Um, some medication for antiemetic. Zofran is the called Zofran.
Okay.
Mm-hmm.
Um, uh, do you take any medication for any reason?
Like what, doctor?
Any medications for, you told me you take paracetamol for the fever, but
For
did
for high body temperature, doctor?
any other medications?
No, doctor.
Okay. Any over-the-counter medications?
No, doctor.
Okay. Any family history of any long-lasting illness?
Uh, yes, my mother she has hypertensive, and my father has diabetes.
Okay. Um, do you smoke?
No,
Do you drink alcohol?
no.
What do you do for a living?
I'm a teacher.
Okay. And does this affect your job?
Mm, yes, doctor. Just only since 2 weeks the fever.
Okay. Did you try any antibiotics for the fever?
No,
Okay. You didn't notice any ear pain,
ear pain. No, doctor.
any shortness of breath?
No, doctor.
Okay. Um, can I ask you about, may I ask you about your intimate relationship?
Yes, doctor.
So, do you follow a safe sex?
Yes, doctor.
Okay. With one partner?
Yes, doctor.
Okay. So, can I examine you, Mr. Muhammad?
Yes. What you want to examine?
Okay, so first I will start with the temperature.
Mm-hmm. 38.
Okay, and may I offer you paracetamol to improve the temperature?
Mm-hmm.
Okay, what about the blood pressure?
Blood pressure 190 over 60.
Okay,
Mm-hmm.
and the heart rate?
120.
Okay, and then I will move to examine your chest.
Mm-hmm.
Okay,
For
so
what? Just for what?
to look for any signs of infection, the chest,
Like what?
chest infection, pneumonia,
Mm-hmm. You mean how to examine the chest?
by auscultation,
Mm-hmm. Looking for what?
looking for any crackles.
There's no crackle.
Okay, and I'll move with the abdominal examination.
Mm-hmm.
So
For what?
any organomegaly,
There's no organomegaly.
Tenderness.
There's no tenderness. There's a scar on the previous bowel scar.
Okay. Lower limb for any skin rashes or anything
There's
that
no
could.
skin rashes.
Okay, so Mr. Muhammad, may I know what's your concern?
Yes, doctor, I want to know what I have.
So I think most likely you have a condition called febrile neutropenia. That
What do you mean, doctor?
it usually happens. It usually happens after with patient with malignancy getting treatment with chemotherapy that would reduce the white blood cells in your system, in your blood system, and that need further confirmation with blood tests and need more investigations with the labs, basically.
Doctor, you mean I can't have the chemotherapy again?
You can have the chemotherapy, but the thing is, this condition might require further observation and to check for the number of the neutrophils, and if fever present, you might take antibiotics accordingly.
Doctor, what you mean by neutrophil?
This is the white blood cells, part of your blood.
Doctor, you mean this may be happen every time I have chemotherapy?
Sorry?
You mean it happened every time I had chemotherapy?
It's not a must to happen every time you have the chemotherapy, but sometimes.
But sometime what? Hello?
Yes, Dr. Rasha, we can hear you. I think
Okay.
from hair connection. Dr. Iman, you can hear us? Okay, I put the timer, waiting for him. Dr. Iman, we can't hear you. Please disconnect and join back.
Okay.
No,
You
we
can't
can
hear
hear
me?
you now. Yeah, we can hear you now.
Okay.
Yeah,
Okay.
continue your concerns, please.
Okay. So do you have any more questions?
Doctor, you want to admit me?
Yeah, sure. You need to be admitted after getting the lab test and confirm the diagnosis, because you need to take an intravenous antibiotics.
Doctor,
2
you tell me
minutes
it may
left.
be okay. It tell me it may be happen to the every time I receive chemotherapy.
It shouldn't happen. I can't guarantee if it will happen every time you take the chemotherapy, because it happens. Some chemotherapies can go smoothly without getting this condition, and some might have uh, febrile neutropenia. So it's not always the case to happen every time.
Okay. Doctor, for how long you want to stay to the hospital?
So usually with the antibiotics given, and the neutrophils start to rise, and then we will decide about the discharge.
Okay.
Okay. You have still 45 seconds. Anything else you want to examine or to add to your questions?
I'm not sure, to be honest.
No problem. We can go to the examiner questions. Dr. Rasha, you can start.
Okay. Presenting your case.
So today I examined Mr. Muhammad, 62-year-old, complaining of fever over the past 2 weeks. He has had, along with it, he has a history of bowel cancer and getting chemotherapy accordingly since 1 year, and the last one is was 1 month before the onset of fever. Most likely he's having febrile neutropenia.
What are other differential diagnoses?
Fever of unknown origin
Mm-hmm.
could be, or what else? Or maybe could be a tumor fever.
Okay. What investigation? How to investigate them?
So first I will start with the basic labs, CBC, looking for the WBC, and renal function test, liver function test, with inflammatory markers, blood cultures, ESR, CRP, with the urine culture and sputum culture as well. And then I would go for chest X-ray, looking for any
But the
signs of.
patient, there's no any sputum.
Okay, but could be as a complication of malignancy, pleural effusion.
Mm-hmm.
Okay, and I would go for
Okay, if all these investigation is negative, what other investigation you want to do?
I would ask for a D dimer and
Why D-dimer?
maybe pulmonary embolism.
This the patient, he is any shortness of breath?
He doesn't have, but could be increased risk according to malignancy.
Based on what?
Because they do have a higher risk of, patient with malignancy have a higher risk of PE, especially with chemo, they have hypercoagulable state.
But I think patient with the malignancy already D-dimer is high.
Yeah, true. So yeah, okay.
Okay. How to manage?
So I will admit this patient. I would give IV antibiotics and will
Which
monitor
antibiotics?
piperacillin tazobactam.
If not response?
I would escalate to Marinum.
If not response?
I would escalate to not sure.
This patient needed to stop the chemotherapy into the next cycle?
No, he shouldn't stop chemotherapy for the next cycle if get treated properly.
What is the precaution or instruction give to the patient in the next cycle?
I'm not really sure.
Okay. Okay, regarding the blood pressure, anything you want to give to the patient?
He was having a normal blood pressure or higher one?
90/60.
Okay, so I would give him IV fluids.
Okay.
One more question from me, Dr. Iman. Would you
Yes.
add any precaution to this patient? Any
Uh,
specific precaution?
regarding isolation, I think
Yes, perfect. Yeah. What type of isolation you would provide?
reverse isolation.
Perfect. Okay. Time's up. Any other question, Dr. Rasha, you want to add?
لا, okay.
Okay. You can comment now, please.
Okay, you did well, but there's some point كان missed في الhistory. The first of all, analysis of the fever. Okay, progressive with duration, will sweat, will what increase, what decrease. Ask about the sore throat and cough and runny nose. Use it to jargon like loose motion, like palpitation. Okay.
Yeah.
Then ask about the chest pain, shortness into the breath, dysuria, and ask about the skin rash. Okay, you didn't ask about any soreness into the private area. Okay, in the CNS, do not ask about the patient, the neck stiffness. Mm-hmm.
Yeah, yes.
Okay, there is okay, in the past medical history, ask about the patient. The past medical, it was previous the cancer colon, but didn't ask about if there's any history of the surgery, because the patient in examination, he was scar in his abdomen. Mm-hmm.
Okay.
Okay, didn't ask the patient any previous admission, didn't ask the patient other immunosuppression medication like steroid.
Okay.
And when asking to the patient, needed to ask the patient in detail when was the last cycle and how to the patient the chemotherapy is given. Because the patient may be inserted into the catheter or Heckman line, you needed to take into the culture from this and need an examination to looking for if there's any bus, if there's any inserted any catheter, any line.
Okay, okay.
Okay. Regarding to history and okay, because if the okay, regarding to the history, regarding to examination, didn't check a patient if there's any neck rigidity to rule out meningitis. Patient presented with high body temperature with the low or the immunocompromised patient. Mm-hmm. And during the history, ask the patient if there is any, if you have any one sex. This is the question is very sensitive questions. You need to tell the patient, I'm sorry for asking these questions, but the questions may be related to your condition, because if ask the patient the questions without saying to the patient the sorry is maybe affected into the your mark, because it's very sensitive questions. Okay. 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 In the patient consent, you didn't tell the patient you want to examine you want to isolate him, and also you didn't tell into the patient yes, and also use the neutrophil jargon is not explain the patient neutropenic sepsis well. Okay, using the jargon like neutrophil, didn't tell into the patient I want to admit you, and also I want to isolate you. Mm-hmm. The second in the differential diagnosis, it didn't ask maybe the patient the first differential diagnosis neutropenic sepsis, the second differential diagnosis may be sepsis into the anywhere into the body. And regarding into the patient, the clinical judgment is ask the patient to do the D-dimer. Patient based on there's no any history into the shortness into the breath, and the patient into the cancer therapy, the already D-dimer is high. This may be affected into the your mark into the clinical judgment.
All right.
Okay. Yes. That's it. Okay. Okay. أصلا okay sorry if يعني do investigation without any baseline, maybe decrease into the mark. Be careful about this point.
All right.
Mm-hmm. Okay. Dr. Bassem.
Yes, I am collecting the marks. All your comments are valid. Thank you, Dr. Rasha, and well done, Dr. Iman. I know it's first attempt with me, but still you have good knowledge. You have good way to approach, to ask, to analyze from the introduction. Although it's a stressful one, I feel you are anxious little bit. You analyze the complaint well. You try to access what could be the reason of any fever. And I will ask you this question now. What do you think the cause of any fever in any patient, not only chemo or cancer patient? So what are the most common infection we had?
Um, Viral infection.
No, no, not classified as viral or bacterial. I want to tell me what could be the organs will be infected.
Chest, upper
Let's
respiratory,
start in a systematic way, from the head down to the toe. Now you can see. Perfect. So
CNS.
it's CNS in the top of them. CNS. How you
Yeah,
can had a clue from the CNS as infection? What's your clue for
within
CNS infection?
confusion,
Okay. What else?
in regards of examination, next stiffness,
Perfect. Perfect. Or seizure, right?
seizure, yes.
So you have to find or to figure out this in your analysis. By the way, the systemic review, you have good systemic review, but it's haphazard. It's not regular one. I want you to start in this way from the CNS, the infection as meningitis or encephalitis. So you will ask about the confusion, as you said, and you
Yes,
can ask about neck stiffness. Do you feel any neck stiffness or confusion or weakness? All of them are clues to have CNS infection, right?
yes.
What the next? The common.
And
I'm not talking about less common. The very common one.
ear infections,
Okay, this is less common, but okay, you can mention it. Any difficulty of hearing or discharge from your ears. What
yeah,
else?
chest infection,
No, no, still before going to the chest. It's
sinusitis, you know?
sinusitis or sore throat, right?
Yeah, yes,
All of them still can be there. Then the one you mentioned, chest infection. It's very common, right?
yeah.
So you have to ask about short of breath or cough. You ask them, but I felt like you are asking from up down. It's not regular one. As I
Okay.
prefer usually the organized approach. The head, the throat, or the neck, then the chest, then what up the chest?
Um, Abdominal infections,
Perfect. GI infection could be.
cre-
So you
gastro,
mentioned already the diarrhea, gastroenteritis, diarrhea, loose motion. Okay, and don't forget the hepatitis, right?
yeah.
Okay, or cholecystitis, gallbladder. Next,
And then the UTI.
perfect. Urinary tract, UTI. So you can ask about dysuria. You asked already, and don't forget the indwelling catheter. Those patients mostly they have a catheter because of frequent admission or whatever. It's not only for the UTI, even for any catheter related to the blood. This is the next system we will ask about. Okay, after the urinary tract will be
Um,
musculoskeletal, right?
yes,
Skin infection, carbuncle or abscess or whatever, or catheter in the skin, indwelling catheter, for permacath or for portacath, for chemotherapy, any catheter or procedure, pacemaker, anything. Okay, and
okay.
the joint could be arthritis. So don't forget those systems. Dental can be there, but it will be again as a source to the CNS. So you can ask it at any procedure. Okay, I prefer when I like when you ask about any history of long-standing disease. And you have the cancer. Why you didn't analyze it? Okay, not only from since when and what the area of the cancer, then what have you done for this cancer? You didn't ask. Only chemotherapy? Not only chemotherapy. Those patients, they will have either surgery or sometimes chemo, radio. So it's not a matter of chemotherapy only. Please don't
Oh,
don't ask only about medication.
okay.
Okay? For you forgot also the allergic history. So it's important to ask about allergy. What do you think the importance of asking about the allergy? What do you think? Why I should ask about allergy?
Because of the antibiotics we will give?
Perfect. So you are going to prescribe medication or antibiotic for this patient. If this patient is having penicillin allergy, you'll be in trouble to start the piperacillin,
Yeah, yes, true.
right? Yeah. Or vancomycin. And this is the medication you have to add to your patient. Any cancer patient with frequent hospital admission, this is for the clinical judgment. What are the medication you have to give? You started with piperacillin, tazobactam. Is it enough?
And I should add,
MRSA covering.
okay.
And then, if not improving, you escalate to imipenem or carbapenem. And if no response, after 48 hours, what you should add? This is for the clinical judgment. What you could add?
This one I didn't know the answer.
Antifungal.
Okay.
Okay. So this is the way how to treat the neutropenic sepsis. It's good to differentiate or to put it in your differential, but you have to put what the source, what the source of your infection, right? You have to have source of infection, right? So neutropenic sepsis means there is source of infection plus leukopenia or neutropenia. So I have to have a source of infection. Where is it? I should give him example, or I should have any explanation. So I will ask Dr. Rasha, what the source of infection here? Any source of
Uh,
infection or just fever?
uh, just fever for chemotherapy, neutropenic sepsis. But you need to do يعني ask all the symptom to rule out other cause of sepsis. For that, ask from the head to the toe to rule out any cause into the other sepsis.
Perfect. So no clear source here, but there is neutropenia, right?
Yes.
Okay. Try to avoid the jargon, Dr. Iman. You have a friend or neighbor
Yes.
who's not in the medical field.
Yeah, I do have.
Imagine you are talking to him or to her. Okay. Imagine you are talking to a relative, cousin, who's not in the medical field at all. You cannot tell her or him that if you have neutropenia or you have diarrhea. Yeah, diarrhea is the common term, but I want you to have simple and very easy words to be understandable by the patient or the surrogate. Okay?
Okay.
This is the way how to discuss and to approach with the patient. With the examiner, you can say whatever you want. Okay? But try to avoid the jargon as well. So white blood cells, don't say WBCs. White blood cells or leukocyte, leukocytic count. Okay?
So I can say leukocytes
Yeah,
to
leukocyte.
the.
Better than WBCs.
Okay.
Or white blood
Okay.
cells if you want to be in full term. Yeah, the next thing, you start with the basic, specific. What specific investigation you want to add here? And I think you mentioned them. Inflammatory markers and septic screening, sputum, blood, and urine. Right?
Yeah, I mentioned them.
Yeah, I know. I mean to be more organized. So general, CBC to rule out leukocytosis, inflammatory marker as specific, full septic screening, and imaging. Bedside test, if you want to say bedside test, What do you want to do in the bedside test? What do you think?
Um,
For the tachycardia,
ECG.
ECG. Good to say and to rate the issue of PE. It's really nice to mention because this is a thrombophilia patient. It might or he might have or she might have the pulmonary embolism because of the cancer itself, right? Pulmonary embolism sometimes present with fever. Okay, so this is the way how to think about the differential. You said neutropenic sepsis, and you mentioned what else you said?
I said only I mentioned neutropenic sepsis and
Be confident whenever you are talking to the examiner. Show him that I understand what the case. Even I don't have a differential, but still I can think about other possibility. Here you put the pulmonary embolism in your investigation. Why you didn't put it in the differential? Okay. Yes, no short of breath. You can mention to the examiner that I couldn't find any short of breath or chest symptom that can give me a possibility of pulmonary embolism. However, uh, it's one of the differential. Okay. Good thing you ask about travel history. Very important to ask about travel history. The HIV questions, you ask only one question about the intimate relationship. As Dr. Rasha said, please be sorry before asking these questions. But what are other questions for the risk habit to have HIV? Is it only sexual transmitted disease?
illicit drugs.
Perfect. So any sharing needles, don't forget it. What
Okay.
else? Any tattooing, piercing, blood transfusion, all of them are risky to have HIV as transmission, a mode of transmission, not only from the sexual relationships, right? This is the way how to think what I have. I think you mentioned HIV as a differential, right? You said HIV.
No, no, I didn't.
Any patient with fever and immunocompromised, you have to put HIV in your differential. And you have to screen, especially those who have risky habits, right?
Yeah.
Okay. Why I could think about HIV if I don't have risky habits? What she might or he might have.
I didn't get it.
Okay. If he doesn't have, this patient doesn't have risky habit like sharing needles or tattooing, what what can be the reason of thinking this is could be or this one could be a HIV infection?
Because if he's taking immunosuppressive medications,
Perfect. He's immunocompromised. And what else? He had a surgery. Maybe he had a
Maybe
procedure.
blood transfusion, patient cancer.
Perfect.
Mm.
So it's not a must to to only have risk habit. He might contract it from a procedure in dental or in many procedure during extraction, during transfusion, during surgery, accidentally, of course. However, nowadays the precautions are more clear and restrict, right? This is the way how to think about a fever patient, and your approach is good, just to be more organized. You mentioned the travel, as I said, the HIV, the systemic review. You have to be in systematic way, from the head down to the toes. If you do this with good confidence, believe me, with this approach, they can give you good mark. They can pass you without using jargons. Okay, take care in overseas countries and centers. They have minus in the jargons, but in the UK centers, they accept those words. Okay, so they accept diarrhea. They accept for example, as you mentioned, diarrhea. You mentioned also something fever. You can all of these words. You can say it. They accept them, but in overseas centers, they not accept, and they can minus you. Okay?
Okay.
Yeah. Thank you, Dr. Iman. You have any question?
No.
Okay, your marks will be minus in most of the skills, especially the physical examination, because you didn't explore the CNS. I think you
In
will
the
learn. Yeah, sorry.
in the examination, so I started with the vitals, and the most important thing is the CNS, because I was confused what to examine.
Not only CNS, I will tell you now what to examine. From the hand itself, as you said, I will examine the hand from vital signs. So I will offer the blood pressure and the pulse, not only as a vital, I should examine the pulse. Those patients, either they have tachycardia, so I can say one of the findings that I have, this patient is having tachycardia, sinus tachycardia, right? This is one of the identifying signs I should say, right? This is from the
Yes.
peripheral, from the hand. Still, I'm in the hand. Some of those chemotherapy patients, they have anemia. So I can say there is pallor, leukonychia, cholionychia, whatever the type of anemia. And those also, cancer colon, they might have iron deficiency. So I can have the anemia signs as a bleeding. And whenever you have cancer colon, you have to ask about bleeding back passage. Don't forget this question, okay? Let's go back to the hand examination, then the pulse, the pallor I mentioned, the pulse. Then I will offer the posture hypotension. Why? Those patients, they might have dehydration. As this patient is having hypotension, I could have also hypotension from the start or hypotension as postural. So I will offer the postural hypotension, right? Then I will
Okay.
go to the neck and the head. I will, first of all, I should do the neck stiffness. If there is neck stiffness, I will say, or I could say this is meningitis. And the lymph nodes. In this patient, I should examine all the lymph nodes you expect in the body. Cervical, auricular, all the groups, supraclavicular, subclavicular, supraclavicular, and downward to the axillary. And I will offer the inguinal. Without doing it, I will offer the inguinal. All lymph node examination I should do. The spleen itself I should examine. Why? Because it's one of the lymphoproliferative organ, right? And the
Yes.
abdominal examination, the scar side, if there is any oozing. I don't know whether it was the surgery done. You didn't ask about it, so you don't know what is the scar. Is there also colostomy? You didn't ask. Okay, so don't forget to ask about the surgery, the allergy, any past history. Not only medical, you should ask about surgical, allergic, and procedure. Okay, so we'll ask Dr. Asha when was the surgery for this patient?
Yes, hemocolectomy.
Only
Patient
colectomy,
bowel
without any
cancer, yes.
colostomy.
Without
Perfect.
any colostomy, yes. But
Perfect.
doctor,
Yes, Dr. Asha, yes.
yes, I want to add something regarding to
Yeah, yeah.
examination. After examine to the general look of the patient, examine the hand if there's the vital sign, the pallor, and examine the head for eye for the pallor and jaundice. Examine the neck if the neck is stiffness. Examine to the mouth if there's any mouth soreness, if there's any tonsillitis. Look at the ear if there's any ear discharge or any if there's any infection, and into the neck into the lymph node, and then examine the heart for any murmur to rule out infective endocarditis because patient high body temperature, and examine the chest if there's any crackling, if there's any a crackle, if there's any chest infection. And after that, go to the abdomen, examine if there's any tenderness, patient have a scar, any organomegaly. After that, examine the lower limb if there's any pitting edema, if there's any scar. And also don't forget if this patient if there's any catheter, if there's any catheter, and patient if there's any inserted the Hickman line, you need to check if there's patient any inserted to the Hickman line.
Perfect,
Quickly
Dr. Asha.
examination quickly.
Yeah, perfect. Yeah, perfect. So those are the finding or the examination steps you have to do. Infective endocarditis is one of the infections I didn't mention, but if you don't have risk, you can suspect it if you have a procedure or line, but not if not you can put it as a differential, okay? But you have to find out also the signs of infective endocarditis. If there is, you
Yes.
have to examine the heart. Anyway,
Heart,
offer
yes.
the examination of the heart for murmur, and you can suspect infective endocarditis whenever you have a murmur. What could be the valve will be infected, Dr. Iman? What could be the most prone valve for infection in those patients if you suspect infective
Typhus.
endocarditis? Perfect. So, in particular, which patient in particular?
IV drug abuse.
Perfect. So as I said, you have good knowledge. Just to need to be organized in your approach, organized in your answers. Otherwise, you can pass the exam with good confidence. Show the examiner the confidence and speak loudly. Don't be hesitant. Uh, Hopefully, you can pass this exam. Okay.
Yes, but there's some type of infective endocarditis affected the malignancy patient.
Mm-hmm.
I don't know, I forget the name. Special type.
Special type
Okay.
of malignancy.
Yes, malignant
Bovis.
patient have
Yes.
infective endocarditis.
Dr. Wad wrote Bovis. I'm not sure about this. What Bovis?
Bovis,
Okay.
yes,
You mean the
colorectal
colon
cancer.
itself? Yeah, the colon. Yes. You mean the organism, not the infective endocarditis type. The organism will infect the heart.
There's other patient infective endocarditis. There are other SLE patient and a cancer patient. There's other
Lickman
type
for
of
the
infective
SLE.
endocarditis. Yes.
Lickman, you won't say Lickman, right? For the SLE.
I think for the cancer and marginal or marginal infective endocarditis, I am not sure. Okay.
Anyway, the organism will
Okay.
be specific for the colon after the colonoscopy, which is a Bovis as written. But for the type itself, I'm not sure if there a type or a name or a term for the infective endocarditis related to the cancer. Anyway, we'll search and we can go now to the comments.
Okay.
Before going to the comment, any question, Dr. Iman?
No, thank you.
You can write your scenario for Dr. Rasha, please.
Okay.
Okay, let's go to the comment starting from Dr. Tahani. Not to ask about catheter inserted, perfect for chemotherapy, neutropenic sepsis. Any fever, ask travel, perfect, and HIV, she did. Many jargon used, yes. Dr. Tahani again, differential neutropenic sepsis, simple infection, yes, need to stop until neutrophil increase. Yes, don't say we can give the next cycle of chemotherapy. You have to refer the patient to the oncology, okay? And multidisciplinary team, Dr. Iman, don't say I will do. You have to do multidisciplinary team approach, starting from the oncology, the hematology, a specialized nurse, Macmillan nurse, the specialized nurse for the chemotherapy, and clinical pharmacists. Okay, you are going to give medication, antibiotics. I mean, so infectious disease as well. You have to involve. Don't treat the patient by yourself. Refer to multidisciplinary team approach. Need admission in single room? Yes, exactly. So reverse isolation will be offered to this patient. History of allergy procedure, Dr. Tani again, if WBCs or white blood cells not increase, we give filgrastim, perfect. The CSF, yes, perfect. Clonal stimulating factor, it's called filgrastim. You have to remember this medication, Dr. Iman. Dr. Wad mentioned, yes, antifungal be considered if no improvement, as I said. Dr. Hind, thank you for the comment. Please don't forget the mucositis, infective endocarditis, or infectious myocarditis, pericarditis, especially after virus illness. The good question, Dr. Iman asked, any sore throat or any previous infection recently, which is also a clue for viral infection. It was good question, Dr. Sarah. If you have positive, Dr. Iman, sorry. If you have positive infection recently, you can suspect viral or post-viral super-added bacterial infection. In CNS, don't forget brain abscess, infective cavernous venous sinus thrombosis. Perfect. Thank you, Dr. Hint. Bovis, yes. Ma endocarditis, what's called? Mammalic. endocarditis. I'm not sure about it anyway. Dr. Iman wrote the case, Mr. Ahmed, 55 years old, with uncontrolled hypertension. Get ready, Dr. Asha, and we'll start after a while. Dr. Abdullah, yeah, suppose, thank you, special thank to Dr. Abdullah because this session was for him, but he offered the opportunity to Dr. Iman because her exam just at the end this week, right? Tuesday, I think. So good luck to Dr. Iman, and thank you, Dr. Abdullah, for giving her the opportunity. He wrote other less common cause of chronic fever, hematological malignancy, vasculitis. Also, fever can be due to metastasis. Thank you, Dr. Abdullah. Dr. Ahmed, marantic endocarditis, sterile vegetation in hypercoagulable states and cancer. Streptococcus bovis with colorectal cancer. Marantic, okay. Really, we are learning. I'm not sure. I didn't hear about this before. Anyway, marantic endocarditis is a term of this infected endocarditis with cancer. Marantic endocarditis. Thank you, Dr. Abdullah, again. Dr. Rasha, whenever you're ready, we can start.
Yes. Yes.
Ready?
Mm-hmm.
Okay, here you go.
Hello. Hello. My name is Dr. Al Mahdi. I am doctor in medical ward today. Can I confirm I'm talking to the Mr. Ahmed, 55 years old?
Yes.
Mr. Ahmed, we are here to ask you some questions and examine you and address your concern. That's okay with you?
Yeah, it's fine.
Can you tell me what brought you in a clinic today?
Actually, doctor, I have been having uncontrolled blood pressure recently.
Mm-hmm. Okay, I'm sorry for your suffering. Since how long you are feel that?
Since 2 weeks.
2 week. When was the last reading?
Last reading was yesterday.
Mm-hmm. How much?
It was 155/92.
92. Okay, since how long you are diagnosed into high blood pressure?
Since 1 year ago.
1 year ago. Okay. What medication are you using for high blood pressure?
So I'm taking antihypertensive
Which,
medication.
you know the name?
I'm not really sure.
Okay. How many tablets? 1 tablet or more than one?
More than one.
Okay, you mean two tablet of two type of high blood pressure or hypertension medication?
Yes.
Okay. Okay. Are you compliant with this medication?
Yes, I am.
Okay. Okay. You mean since 2 weeks the blood pressure was high? Before that was blood pressure was controlled. Am I right?
It's fluctuating. Sometimes it's controlled, sometimes it's not controlled.
Oh, it's not controlled. Okay. Okay. Can you tell me, do you have any history of headache?
No.
Any blurred vision?
No.
Any weakness anywhere in your body?
Yeah, I feel weakness sometimes in both arms.
In both arms. Since how long?
Since 6 months, 6 to 7 months.
6 months. Can you tell me more about the weakness in both your arm?
I start to notice that I can't like brush my hair.
Uh-huh.
Yeah.
You have weakness in combing your hair.
Yeah, when I try to
Yes, you need to support why change it to their position from the standing to sitting.
Yes.
Since 6 months?
6 to 7 months.
Okay. Okay. Do you notice any history to the problem, to the sensation, to the anywhere?
Sorry?
Problem to the benza needle sensation?
No.
Okay. Any history of fit?
No.
Abnormal movement?
No.
Any loss the control to the back passage and water work?
No.
Any blurred vision?
No.
Okay. Any history to the loss the control to the, okay. Any history of chest pain?
No.
Any awareness of the heartbeat?
No.
Uh-huh. Any history of shortness of breath?
No.
Any leg swelling?
No.
Okay. Any history of high body temperature?
No.
What about your weight?
Yeah, I have noticed a weight gain
Since how long?
since 6 months as well.
Uh-huh. It was intentionally or not intentionally?
No, unintentionally.
Okay. Any recently change into your diet or your exercise?
No.
Due to the increase into the weight into the special part into your body, like your hand and your feet and your tummy.
Yeah, more in my tummy.
Okay. What about your appetite?
It's the same.
Okay. Any lumbar bump to the anywhere?
No.
What about, okay, any history of tiredness?
No.
Any history of neck swelling?
No.
Any weather preference?
No.
Okay. Anyone comment you bail them before?
Sorry?
Anyone comment you bail them before?
What do you mean, doctor?
Anyone comment you bail? Yeah, you mean like bail?
No, 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 no,
Okay. Any bleeding from any side?
no.
Okay. What about your sleep?
I'm sleeping very well.
Any history of snoring?
I didn't notice.
Okay. Okay. Do you have any history of skin rash?
Skin rash, I start to notice in my abdomen
Mm-hmm. Okay. Since how long?
since it's all with these symptoms, weight
Okay.
gains.
Any skin pigmentation? Any skin spot?
Yeah, actually it's a skin pigmentations around my abdomen.
Uh-huh. Any other site into your tummy? At the other site apart from your tummy skin pigmentation?
No,
Uh, okay. Any history of okay. Any history of tummy pain, tummy distension?
no. But I
Any change?
noticed
Uh-huh.
the weight gain around my tummy especially.
Yes. Okay. Any history into the change into the bowel habit?
No,
And history into the blood vessels from the back passage?
no.
What about your water work?
It's fine, doctor.
Any change into the amount or frequency or color?
No, no,
Uh-huh. Any history into the joint pain?
no,
Any morning stiffness?
no.
Mm-hmm. Okay. Any history of okay? Any history of tightness of the skin or back pain?
No,
Any history into the back pain?
no.
Okay. Okay. Any medical condition I should aware of?
Well, I was diagnosed 1 year ago with disease. It's called COPD.
Mm-hmm.
Yeah,
Okay. Okay. How to diagnose this, the COPD?
they diagnosed me with the COPD and chemotherapy.
Okay. Apart from the COPD and high blood pressure, any medical condition?
No,
Okay. Okay. Show me the medication list, please.
so I only take the bronchodilator with inhaled steroids.
Steroid, inhaled steroid. Since how long? Since 1 year.
Yeah, because yeah,
Okay. Any recently changed the dose of steroid or added the dose of steroid?
yeah, they increase it to me in the clinic because I do have symptoms.
When increase the dose of steroid exactly?
This 6 months.
What?
It started to increase in 6 months and
6
increased.
months. Okay. You noted this, the symptom is started after changing the dose of steroid?
I didn't observe much, but I could say yes, could be.
Mm-hmm. Okay. Apart from steroid, any other medication?
No, other than the bronchodilators with the steroid, no.
And also the medication of high blood pressure, yes?
Yeah,
Okay. Any recently changed or added any medication?
no,
Okay. Any allergy from any medication?
no,
Any over counter?
no,
I'm sorry for asking this question. Any party drug or recreational medication?
no,
Any surgery before?
no,
Any blood transfusion?
no.
What are you do for living?
I'm a teacher.
How much is the symptom affected to the job and daily activity?
It really affects my daily activity.
Mm-hmm. I'm sorry for that. I will refer to the occupational therapist department to help you regarding the issue. Do you smoke?
Yes,
How many cigarettes over how long?
yeah, 2 cigarettes. I'm trying to stop since I was diagnosed with COPD.
Uh-huh. But
Yeah,
not to stop, yes?
no, I couldn't.
Yes, apart from your health, the smoker, you need to stop into the smoke because the smoke will affect into your health, especially the COPD. We can help you by referring to the smoking cessation clinic if you don't mind. That's okay with you.
Yeah, okay, doctor.
Do you drink alcohol?
No.
What about your mood?
With all these symptoms, I'm starting to feel a bit depressed
Mm-hmm.
about my health condition.
Okay, Mr. Ahmed, I'm sorry for asking this question, but maybe related to your health. Any extramarital relationship? Are you sexual active?
No,
Any extramarital relationship?
no.
Okay, can I examine you?
Yeah, sure.
The first of all, the general look of the patient, the general surrounding, and also I want to examine the blood pressure in both sides and the vital sign, البلس rate, yes. Uh-huh.
Okay, so the general look, I have the moon face,
Uh-huh.
and there is acne in the face.
Okay.
Blood pressure is 160 over 100.
Okay. Mm-hmm. Okay,
Yeah.
I want to ask the patient if there's any the pain at the carpal sign, if tapping, if there's any carpal tunnel positive.
No.
I want to examine the patient, the proximal myopathy, if there's any tenderness, if there's any proximal weakness.
Yeah, there is weakness, but no
I want to
tenderness.
yes, I want to examine the face of the pallor and jaundice, examine of hirsutism, acne, and mouth if there's any candida infection.
Yeah, there is hirsutism, acne, but no candida.
Okay, I
Or
want to examine the back of the neck if there's any acanthosis nigricans.
yeah, there is acanthosis.
Okay, I want to examine the heart, the base of the lung, if the base of the lung, if there's any heart failure, if there's any raised GVP.
No, nothing.
Okay, I want to examine the abdomen to looking for the stria if there's any organomegaly.
Yeah, there is a stria, but no organomegaly.
Okay, I want to examine the knee if there's any crepitation.
No,
Lower limb if any pitting edema.
no, nothing.
Okay, Mr. Muhammad, what's your concern?
So, doctor, what do you think I'm having?
Okay, regarding to your symptom that you have, most probably you have a condition is the called Cushing syndrome. Is the medical term for the medical condition may be related into the steroid which using for treated for treated your condition like obstructive lung disease.
2 minutes left.
Okay, what we need to do now, some blood tests and imaging to confirm our diagnosis. Any other concern?
Will these symptoms go away if I get treated?
Uh, And highly appreciated your concern. Yes, after controlling into your condition, and yes, the symptom, the blood pressure, yes, the blood pressure, we can control it.
Okay.
Any other concern?
No, doctor.
Okay, apart from that, you need to stop into the smoke. And regarding to the steroid, I will refer into the chest doctor and group specialist to provide into the proper management plan.
Okay.
Okay. Any other concern?
So doctor, you told me that it's second to steroid. Should I stop steroid in that case?
Regarding as okay, regarding to the steroid, you have not needed to stop into the steroid, but maybe need to decrease into the dose.
Okay. Thank you, doctor.
Okay. You want to go to the examiner question? Dr. Rasha, any concern else? Okay. You can start now.
Okay, so can you present your findings?
Okay, Mr. Ahmed, 55 years old, non-case of obstructive lung disease and hypertensive, recently presented with uncontrolled blood pressure, associated with an increase into the weight, is most likely into the tummy, and also with history into the weakness into the both upper limb. Apart from that, the patient is used recently since 2 weeks to medication of high blood pressure and increase the dose of the steroid since into the 6 months. On the examination, the patient, there's the sign of Cushing syndrome in form of moon face, acne hirsutism, and there's abdominal striae and proximal myopathy with high blood pressure into the both side.
Okay, so can I know what's your differential?
Yes, my differential diagnosis, the first of all may be Cushing syndrome as steroid-induced Cushing syndrome. The second differential diagnosis is the first my differential diagnosis, the steroid-induced Cushing syndrome. The second differential diagnosis, the Cushing disease. Apart from that, the patient don't have any history of headache or blurred vision, and there's no any history of headache or blurred vision. Any other pituitary involvement. Okay.
Okay, so what you will do for investigations?
Apart from the basic investigation, CBC, LFT, inflammatory marker, I want to confirm the patient steroid by 24-hour urine for steroid and low dose dexamethasone suppression test.
Okay.
What
else?
Yes, if positive, proceeded into other investigation. If negative, that's meaning the steroid-induced Cushing syndrome.
Okay.
If positive, you need the complete other investigation like ACTH adrenocorticotropin releasing hormone and high dose dexamethasone suppression test.
Okay, and how can we know if it's pituitary or adrenal in that case?
Yes, regarding to the pituitary increase ACTH, and regarding to the adrenal, ACTH is low.
Okay.
Yes, pituitary increase ACTH, adrenal ACTH is low.
Okay, and treatment?
Treatment, the patient education and counseling, and patient controlling into the blood pressure, and regarding referring to the group specialist. Regarding to the steroid, you need to controlling to the COPD, and I think decrease the dose of steroid.
Okay. Anything else?
Like what?
In the management.
If the patient is steroid induced, you needed to control symptom, the COPD, and decrease the dose of steroid. If the patient pituitary causes, depending on if the pituitary causes may be needed to the patient the surgery or yes, patient the surgery. If the patient adrenal cause, may be surgery or ketoconazole, antifungal treatment.
Yeah.
If the
Okay.
patient ectopic, treated underlying the cause.
Okay. So what are the causes of Cushing syndrome?
Cushing syndrome, maybe pituitary cause, maybe adrenal cause, maybe ectopic, maybe steroid induced. Ectopic like lung cancer or other
Okay.
cancer.
Okay.
Are you done, Dr. Iman, with the question?
Yeah.
Okay, I will ask her one question. Dr. Rasha,
Mm.
do you think any other precaution you want to give to this patient regarding his inhaler?
Yes, need to the patient to use it spacer and patient gargling. But
Yeah.
forget all told the patient about
Yeah,
that. Yes.
perfect. So,
Mhm.
yeah, so you think there is possibility to be as from inhaler, right? Side effect of
Yes.
the.
Mm-hmm.
Okay. So you have to give some instruction regarding the use, spacer, and being compliant to the technique, right?
Yes.
Plus the gargling. Perfect. Okay. Well done, Dr. Dr. Iman, please, you can comment.
Yeah, she did really well with this case. I don't have much comments on her, to be honest. Except for one small thing, is the complications of Cushing. When she did the examination, I think not the examination, and she should ask for symptoms of complications of hyperglycemia. That's it. No, nothing special.
Again, doctora, I can understand.
The
Yeah.
complication, the hypertension and hyperglycemia,
Yeah, and the osteoporosis because of the
osteoporosis, and osteoarthritis for the
yeah.
weight
Yes,
gain.
I check osteoporosis by check
Perfect.
the osteoarthritis and check carpal tunnel.
Perfect. Yes.
Okay.
Yeah, really, it was perfect performance, Dr. Asha. I think you didn't, even the OSA, obstructive sleep apnea, you asked about snoring.
Yes.
But I prefer to ask the past medical history earlier. Imagine if you ask the past medical history earlier. You could do more screening and you could be more calm during taking the history. Although you got the case from the question of weakness, see the importance, not only Dr. Asha, the all candidate, the importance of a systemic review question. She asked about weakness, and the answer came as yes, I have weakness in my arms, and it was the clue for the case. So either to ask about the long-standing disease earlier, and you can catch the case as a COPD management and steroid, or the systemic review question. It's one word can give her or can give you the clue. The systemic review, believe me, is one of the important steps. Some doctors they are just neglecting here this, but believe me, it's one of the important questions you have to do in organized and systematic way. The weakness here give you or give Dr. Rasha the clue about the case. It was there. She analyzed it more. Where exactly? And she said to her, "I have it whenever I comb my hair." So she realized that it has or she has proximal myopathy, and she confirmed that from the question of standing from sitting without support, there is also weakness. All this going with something related to the proximal weakness or proximal myopathy. In brackets, Cushing disease, Cushing syndrome, or whatever the reason of the Cushing. Okay, she started to approach more why this patient is having Cushing, and she reached to the diagnosis. What other causes could be there as a cause of hypertension and controlled hypertension? This is an open discussion, not only our case today. What are the other cause of uncontrolled hypertension you could have in this patient or other patient? Dr. Rasha, what do you think about the herbal? Is it possible?
Yes,
Herbal remedies.
الهربل and also yes and other
What herbal remedies it can cause hypertension?
I don't know specific name.
Licorice, right? Yeah, the licorice.
Yes. Mm-hmm.
So you can ask, but specifically about this or any herbal remedies you are taking. So the patient will take antihypertensive medication, but still he has hypertension. What other things you have to ask about? Simply the salt.
Party drug. Also.
Party drug you mentioned. Salt itself, the diet. Are you compliant to the diet? Right? And you can give it as an instruction at the end. Please be compliant to the diet, or I will refer you to the dietitian. It will be included to the team. Because most of those patients, he will take the antihypertensive, but still he can eat whatever he wants. Okay? This is the second. These are the external factor. We'll talk about the internal factor, not as a Cushing, another patient. You might have acromegaly. So from the CNS or pituitary, acromegaly, right? And Cushing disease from the CNS or from the pituitary itself. Go downwards to the to the cardiac cause. What could be? Sorry, not fuchromocytoma, the coarctation of
Coarctation
aorta.
aorta.
Perfect. And other causes of the endocrine after cardiac. Endocrine cause will be
Yes,
fuchromocytoma.
الكوشن fuchromocytoma. Yes.
Yes, and Cushing syndrome now in the kidney or suprarenal, and hyperthyroidism or thyrotoxicosis. Right?
Constant.
Sorry?
Cons.
Cons.
Cons, perfect. Yes, cons as well. Of course, if you have family history, you have to think about those things, about the other inherited factor or causes of hypertension, right? Let's go to the next system, the renal itself. What are the renal cause of hypertension? Dr. Rasha?
Renal artery stenosis and
Okay,
other
it's renal
polycystic kidney
artery,
disease.
polycystic kidney,
other interstitial nephritis.
interstitial or glomerulonephritis.
Oh yes, nephritic. Yes.
Okay, nephritic syndrome. And the next, vasculitis, musculoskeletal. So include, you ask about this stiffness. Why the stiffness is important to ask? Lupus nephritis, or sorry, lupus itself, SLE, can cause. Lupus nephritis can cause. What else? The vasculitis, Takayasu,
Takayasu, scleroderma renal crisis.
scleroderma, rare, perfect. And other vasculitis, right?
Yes.
Then I think we cover most of them. Then you can talk about the herbal cause. We mentioned already the licorice can cause, and the recreational drugs as well. This is also external, but internal organ or internal cause we mentioned already. If you don't have all of them as positive, what you call it?
Essential.
Perfect, essential. But before saying this is essential, what you have to do?
Before
Blood pressure.
essential.
Yeah. Home monitoring.
Cause.
Yes.
Home monitoring. Why? Because you have what's called what? Why it's called hypertension,
Yes.
right? So
Mhm.
before saying this is essential, I have to rule out the white coat hypertension.
Mm-hmm. And also, I need to ask the patient where's the blood pressure is high into the hospital, and yes, forget
Exactly.
in
So
the
you'll do
hospital
home
and in the
monitoring.
clinic. Yes.
Yeah, so you'll do home monitoring. It will be clear if it's hypertension at home even. So this is essential. If just he had it in the clinic, you can say this is white coat, right? Any missed cause we miss in this scenario? Anyone want to add system or other cause he knows? Okay, so we cover most of the causes you have to ask about, and our case today was about Cushing. Usually try to say this term, Dr. Rasha, ACTH dependent or ACTH non-dependent. You will show the examiner that you are understanding what the Cushing management or investigation. Okay, yes, you mentioned the free urinary cortisol and low dexamethasone and high dexamethasone, but all of them, why you are doing all of them? Just to localize and to have a look for the ACTH dependent or non-dependent, right? So if you say this
Mm.
word, he will know that you are understanding the Cushing disease. Is it ACTH dependent? ACTH dependent means pituitary disease from the pituitary, I mean, or ACTH non-dependent will be the cancer, or could be the suprarenal itself, right?
Mm.
Or the
Or
medication from
ectopic
outside,
and
ectopic,
medication.
exactly,
Yes. Mhm.
ectopic or factitious, right? Yeah, don't forget if you have patient with a smoking history, what you can add to your differential. Significant history of smoking. It's very important one. Still related to the diagnosis, by the way. Dr. Rush and Dr. Iman.
Smoker and high
Small
blood
lung
pressure.
cancer. Small lung cancer.
Perfect. Yes, small cell lung cancer. I can put it one of my differential. Even
But I
if
think the patient, the weight loss is not weight gain.
okay, as cancer,
Mm.
but still you can put it as a differential. I didn't say this is the case, but still you have to put it in your differential. Patient is smoking for a long time, and he has, for example, especially if he has weight loss, of course, you have to put it in the differential. However, if no weight loss, still you can put it one of the differential. I should roll it out by doing, as I said, the ACTH level, if non-dependent. Here it will be non-dependent, right? Then the high dexamethasone will be negative, right? So I will go to the next step, which is localize the lesion.
Yes,
So I
localize
will
the
do
lesion. Mm.
so I will do either CT chest or CT suprarenal, right? Thank you, Dr. Rasha.
Yes.
Really,
Mm. But I have one question
yeah, sure,
regarding
sure.
this patient. You need to decrease of the steroid or stop because the patient
Perfect.
COPD.
How you answer? Perfect question. And I like the concern. All concern from Dr. Iman was to the target.
Mm.
What do you think? Will you
And
stop
also, I
it?
like this answer. Mhm.
What's your answer and how to answer it properly?
I answered this patient to decrease the steroid, but I am not
Okay. Do
sure.
you think, yeah, do you think this is your decision?
Referral to respiratory.
You mentioned it. I will refer you to the lung doctor. You mentioned a chest doctor, but better to say the lung doctor. He will manage this issue. So either either it will be decreased. Let's talk about the scientific point. Either to be decreased, or what other reason could be the idea behind the Cushing in this scenario? And I mentioned it during the discussion. Dr. Rasha,
Yes, what?
what could be the reason of the Cushing in this scenario?
Cushing may be related to the steroid.
Yes, is it the dose itself? Is it the dose or
Yes,
something
because the
else?
patient recently increased the dose.
And do you think the dose as inhaler one will be the reason? how much the absorption of the inhaled steroid to the circulation to be judged. This is the reason of his Cushing.
But sometime maybe happen.
Okay, I didn't say it doesn't happen. It do happen, okay, or it does happen. But for how long, or sorry, for how frequency? Is it commonly to happen? Is
It's
it
not common
common
to happen.
is it common as the systemic one, the IV or the oral?
It's not common.
Perfect. So what I should do to correct this, or to analyze it, or to investigate, how to investigate? Is it related to the dose? Is it dose dependent or technique dependent? You got my point.
Yes, but I am not sure.
Yeah, so you might have wrong technique. He's not taking the spacer. You are not sure if he's doing the good technique. You have to ask this, by the way. I would like to ask if you do the technique for the inhaler properly. Okay?
But if the patient tell me, doctor, recently the COPD, my COPD is not controlled, for that doctor advised to me to increase the dose.
Yeah, so here you will refer the patient again to his primary or to the lung doctor. He will manage either the dose, or he will search why this patient is having exacerbation. So it's not the matter of increasing the dose of steroid. Maybe he's not taking the medication properly. Maybe he's still having the trigger and he's still smoking. How he will be controlled, right?
Mm-hmm.
Anyway, what I want to say, refer this patient to the lung doctor, as you said, and he will decide what to do with you. Okay, after confirming the diagnosis, of course. This is the way how to answer this concern properly. So this is not your decision, as well as it's not confirmed yet. So I will refer you to the group of doctors, and they will decide according to the management plan, according to the investigation. Okay?
Okay.
Not only in this scenario. I want to say this is not only for this concern, or not only in this scenario. Whenever they want you to answer a medication titration, and it's important to keep the patient on this medication, refer to the primary, either to stop or to decrease. But as a scientific point, if he wants you to say this, okay, answer him. I cannot stop abruptly the steroid. Why, doctor, you don't want to stop the steroid abruptly? So now you can answer him. What is the logic point, Dr. Rasha? Why I don't want to stop the... If he asks you, I would like to stop this medicine, doctor, or you like to stop me this medicine, and the examiner asks you, would you like to stop this medicine, doctor, for this patient?
I think depending to the patient's COPD controlling or not, maybe decrease the dose.
Okay, my question about stopping the steroid, not decreasing.
I am not sure. I am not sure to stop into the steroid to the patient's COPD.
Okay, if you want to stop this medicine for the patient, would you stop it abruptly?
Inhaler steroid can be stopped suddenly, not gradually.
Okay, in general, if the patient having Cushing, and the question is, would you stop the steroid to the patient? What's your answer?
Yes, if patient on the steroid needed to stop into the steroid gradually.
Exactly. Why?
Yes. Mm.
Why not?
To prevent it, yes, to adrenal insufficiency.
Perfect. This is the answer. This is what I want you to say. If he asked you, by the way, not to be volunteer by you, I will not stop, because if I stop suddenly, no, I will refer to the MRP or the primary, and he will decide. But if he specifically asks you, doctor, would you stop the steroid? Sometimes they want you to ask this knowledge. Will you stop the medicine immediately if it is the reason? Now you can answer with this one. No, I don't prefer to stop it. Why? Because I might precipitate the additional crisis in this way. Okay?
Okay. But I think in the clinical practice patient on the secondary steroid, secondary caution when the patient to the steroid, like patient SLE or systemic lupus, not to stop into the steroid, yes? Even in the
Yes.
patient secondary caution,
No, we are not stopping.
not to stop, yes.
We are titrating or decreasing the dose. Okay?
Yes.
They never ever stop steroid with side effect abruptly. By the way, it came as a communication scenario. Patient with steroid, and he had complication, whatever the complication of the steroid. And he will ask you, doctor, will you stop my steroid? Because I found a lot of complication. How you answer him?
Yes, it's not if we stop steroid, needing to stop steroid gradually. The first of all, needed to the decrease into the dose. But if the
Okay,
patient, yes, like the chronic illness, like systemic lupus of rheumatoid arthritis or patient asthma or COPD, needed to continuous steroid.
yes, I didn't say to continue or not. I'm asking to stop it. Will I stop my
Not to stop, not to
steroid?
stop it, not to stop it suddenly. Stop it
Yes,
gradually.
this is what I want you to say.
Mhm.
Whenever you are in communication scenario and there is side effect of steroid and the surrogate or the patient ask you, doctor, will I stop this steroid? So I will answer him clearly, no, please don't stop this medicine by you or by yourself. I will refer you to the doctor or the primary or to the lung or whenever or whatever the team, and along with with them their decision, you can titrate or decrease the dose, but don't
Mhm.
stop the steroid by yourself. Okay, be safe. This is the safest answer whenever you have steroid side effects. Even with the side effects, avascular necrosis or Cushing, hypertension, we are not stopping the steroid immediately or abruptly. Okay, you need to be titrated. You got it, Dr. Rasha?
Yes.
Okay, any other question?
Yeah, can we add pseudo Cushing as a differential?
Pseudo Cushing. When you have to add the pseudo Cushing, Dr. Iman.
Uh, excess alcohol,
Perfect. Or
anxiety or depression,
okay, one more. So depression.
obesity.
Perfect. Obese or alcohol intake. Those are the risky people or groups who have the pseudo Cushing. And how to do investigation for pseudo Cushing?
With the low dose dexamethasone,
And
ACTH.
no, something else. The diurnal variation of steroids,
Okay.
right? So you will check the morning and the evening steroid. Usually we have diurnal variation, right?
Yes.
On those people with pseudo Cushing, they do
Mm.
have the diurnal variation. But for the Cushing itself, they don't have the diurnal variation. Always high, right? Always they
Yes.
will have high dose of a high level of steroid. Isn't? Okay. Any other
Yeah.
question, doctor?
Yes.
What other question you want to ask?
Yeah, that's it.
Any other question? Dr. Rasha, you want to add any question or to ask? Anyone has a question? Okay, now we can read the comments. Doctor, no name, when asking about types of Cushing, we should add pseudo Cushing. Perfect, good question, and we answer it already. Dr. Abdul Hamid, cons, yes, this is one of the renal causes. I think it will depends, Dr. Ines, and on which specialty prescribe it. Perfect. This is the best answer. I will refer you to the primary team. This decrease or tapering, maybe the frequency, almost nothing tapering. So tapering, the word or the term they want to hear. Tapering instead of saying I will stop. Okay? Never ever stop steroids in particular or any medication patient kept on for long time. Even it has side effects unless the patient life will be threatened. Okay, like for example, methotrexate. Patient controlled well on methotrexate as a joint condition. Suddenly, he took for medication like trimethoprim and he had leukopenia or anemia, or a bleeding, severe anemia. What you will do? Will you continue the methotrexate? Here I can say hold, the word or the term hold. I will hold the methotrexate until correction of the blood component, the anemia, thrombocytopenia, or leukopenia. Then I will resume it back. But I cannot say I will titrate or I will decrease. So it depends on the medication and it depends what the side effect. Is it life-threatening? If life-threatening, definitely I will stop or I will hold. The best word or the best term is to hold. Hold means I will not give the next dose. Maybe the next dose after 1 week, maybe after 1 month. Anyway, I will not give it unless the complication managed. If managed, then I can restart the medication back. So this is the way how to be very clever in your answer whenever the medication or whatever the medication is. Okay? Any other question? Perfect, Dr. Rasha. I can see the difference between the performance before and now. Really, it was perfect performance. You ask all questions. The examination was to the point. Everything went smooth. No jargon. And the examination steps also was perfect. Really, I don't have comments, so you can get a good mark. 26, maybe 28 full mark. Because no skill I can minus you. Any
Thank
other
you.
question? Yeah, most welcome. Any other question, Dr. Rasha or Dr. Iman, before ending the session? Anyone want to comment? Okay, 2 cases were perfect today as a common neutropenic sepsis, and the other case as uncontrolled hypertension, and the case was Cushing or iatrogenic Cushing or medication-related steroid-induced Cushing, whatever the term, but it's still one for the differential. Thank you again, Dr. Rasha and Dr. Iman. Good luck, Dr. Iman. Message me if you want anything else before your exam, and best of luck in your exam. Thank you, everyone, for the attendance today. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ines.